Hi, my name is Naazish Bashir and I'm a research fellow at Sick Kids Hospital here in Toronto, Canada. On behalf of my co-authors, Tom Walters, Anne Griffiths, Sheena Ito, and Wendy Unger, I'd like to introduce to you our paper entitled The Cost-Effectiveness and Clinical Outcomes of Early Anti-TNF Intervention in Pediatric Crohn's Disease. Please allow me to walk you through our paper. Did you ever wonder what would happen if newly diagnosed children with Crohn's disease received anti-TNF treatment earlier rather than waiting for other drugs to fail? We did. The cost-effectiveness of this type of treatment algorithm hasn't been explored before, and so we looked at an economic evaluation and the clinical outcomes of such a treatment strategy. Currently, anti-TNF treatments are indicated for use in patients who have not responded well to other treatments, as stated on the product monograph. However, drug plan decision makers require cost-effectiveness evidence to inform funding decisions if decisions warrant a second look. Traditional standard care in Crohn's disease involves an induction phase with corticosteroids or enteral nutrition and possibly other drugs to induce remission, followed by a maintenance phase with immunomodulators. If patients don't respond well, then treatment can be escalated to an anti-TNF alpha drug like infliximab. We compared this standard step-up strategy to a strategy in which anti-TNF is given early or within the first 3 months of diagnosis, with or without other drugs, to kids with moderate to severe Crohn's disease. We based our study population on an observational study with 28 clinical sites across North America called the Risk-ProKid study, and we modeled the course of Crohn's disease in 360 propensity score-matched patients over 3 years. Our Crohn's disease model had 7 health states. Patients would start with active disease. They could then go into remission. They could stay in remission, or they could relapse back into active disease. Patients could experience adverse events, or they could need surgery or hospitalization. Following surgery, they could experience complications or go into surgical remission. As typical of microsimulation Markov models, all states eventually go to death, but nobody died in our study. Our probabilistic analysis showed that over 3 years, the average cost of the early anti-TNF intervention was over $127,600, with about 94 weeks in steroid-free remission, and the standard care intervention cost over $96,500, with about 83 weeks in steroid-free remission, resulting in an incremental cost of over $31,000 and 11 more weeks of steroid-free remission for the early anti-TNF strategy, translating into an incremental cost-effectiveness ratio of $2,756 per steroid-free remission week gained from a public health care payer perspective. We also ran the model from a societal perspective, which included the public health care payer costs, as well as societal costs such as caregiver time losses. From a societal perspective, the incremental cost per steroid-free remission week gained was over $2,900. Our study had some notable key findings. Firstly, the early anti-TNF strategy was clinically beneficial and potentially steroid-sparing, but it was not cost-effective. Secondly, the ICER was very sensitive to the price of infliximab. Thirdly, the time in steroid-free remission is a clinically relevant endpoint compared to looking at the number of people in remission at a given time point, particularly because of the flip-flop between active disease and remission. Many economic evaluations report results as cost per quality adjusted life year, or cost per QALY. But for children with inflammatory bowel disease, health utilities have not been determined so that QALYs can be calculated. It's quite possible that kids experience IBD differently than adults, so using adult utilities would not be appropriate. If we want treatments for kids with IBD to be evaluated by decision makers on the same playing field as treatments for other diseases, then it's important that appropriate QALYs be generated.